Great. So hello, my name is Janine Gleba. I'm the Advocacy Manager at United Ostomy Associations of America. I'm also going to be a moderator this evening. And UOAA, I should say, is very excited to collaborate with Byram Healthcare to bring you this special event where we're going to be talking about supporting your patient rights to get the supplies that they need. Next slide. So today we are going to talk about how you can help your patients understand their supply rights and improve access to supplies. Geez, there's so much I want to say. So we'll just jump right into it. I'm going to talk a little bit about World Ostomy Day in 1 second, but we're really joined by a terrific group of panelists who are very passionate and dedicated to the ostomy community. And I'm just going to let each of them introduce themselves, just a couple of quick sentences so you can get a feel for who they are. And I'm going to start off with Brett from Byron Healthcare.
Sure. Thanks, Janine. Really excited to be here today. So I promised Janine I would keep it brief, but I'll probably go maybe just a touch longer than everyone. So my name is Brett Cromer. I work for Byron Healthcare as the director of our Ostomy Center of Excellence, customer service center in Downers Grove, Illinois. So what does that mean? If you or one of your patients calls into Byram to place a reorder and wants to talk to a live customer service professional, that's the team that I get to work alongside with every day. So I've been on the team at Byram for about 3 years and have been in part of the ostomy community for, oh gosh, a long time. I've been affiliated with Byram, who's helped our support group in Downers Grove for a number of years, but my tenure as an ostomate goes back to when I had surgery as a teenager and for Crohn's disease and had a colostomy, which is now an ileostomy. So I'll spare you how old I am, but I will tell you that my nurse at the time was an enterostomal therapist. And one of the reasons that I'm so passionate about this today is she paved the way for me, made sure I had the supplies, made sure I had my education, I made sure I knew where to get my supplies, made sure I had all my insurance information, a lot of the things that everybody on the call does today. And we really understand, oh gosh, and she knitted me a scarf. I was right out of Beaver Cleaver. So it was a nice experience for me. So fast forward to today, gosh, we understand how complicated the medical industry can be. We understand how important you are at being that key link at making sure that patient is set up for success. We also understand that every patient is different, every size, every shape, every stoma is different, every skin condition is different, and that can lead to lots of different complications. Put that on top of trying to help the patients navigate which supplies to use and navigate where to buy them and complicate that with what kind of insurance they have. Everybody is so different, and we understand how complicated that can be, but we also understand that critical role that you all play to help those patients set you up for success. So for today, we hope that we can share, answer questions, and share with each other. We learn best from each other. We hope that we can learn from you, but between Barbara and Sue and Steve, we hope to answer as many questions as we can once we kind of walk through our program, and we encourage you to ask questions. So thanks for being here today. We're really excited to be doing this. And Barbara, would you like to go next?
Hi, I'm Barbara Dale. I am a registered nurse and a wound ostomy continence nurse working in home health in rural Tennessee. I've been doing this since 2001, so 20 years. I do not have an ostomy. My daughter had one when she was a baby, and I was actually a nurse then, but I really didn't know anything. I stay in home health because there is nobody. It's very hard for ostomy patients to get help once they go home, once they leave the hospital, in most situations, unless they live in a very metro area. And so I do our supplies for our agency. We do hospice, home health, and private duty, and help ordering. And I also see patients for our home care population.
Great, Barbara. Thanks. Glad you're part of our panel today. Sue, would you like to go next?
Sure, thanks. Hi, I'm Sue Muller. I've been a certified wound ostomy and continence nurse since 2008, and I have been a colostomist since 2004. I recently retired from full-time work, but I've worked in hospitals, home care, and acute rehab. I'm also currently the co-chair for the UOAA Advocacy Committee and have been working on the committee in other capacities for 5 years. And I've also been very active in my support group through UOAA for about 17 years.
Awesome. Thanks, Sue. Your support group does great work. It's great to take your ostomy experience and bring it into the nursing profession. So thanks. Steve, want to bring us home?
Hi, Steve Van Devender. I'm calling on this call from Bloomington, Illinois. I am president of the Peoria chapter of the United Ostomy Association. This last August, I celebrated my 24-year anniversary of having an ileostomy. For the last 43 years, I've been in medical sales, everywhere from general medical line stuff to orthopedics, where I went into surgery with orthopedic surgeons, to wound care, with doing the wound vac and some other things, and actually have had the opportunity to see 3 total colectomies done in person. And it is really cool to be able to see peristalsis in action. And then from there, for the last 8 years, I've worked for one of the major ostomy manufacturers as a sales manager, and being able to call on hospitals, home health agencies and other facilities, and been able to see a tremendous amount of ostomies with patients with a lot of difficulties, trying to help them figure out how to pouch. I retired at the end of 2020, and I'm doing a lot of volunteer work for UOAA. And then I also do a lot of teaching to the student nurse programs in my area on what I call basic ostomy care. So kind of trying to teach them early as to what ostomy is all about. And I'm thrilled to be here.
Okay,
Awesome.
next slide.
Thanks, Steve.
All right, it's a great group we have here, so you're going to really learn a lot. I'm excited to hear some of the answers myself. Before we get started, I just want to give a little background to everyone that every year in the United States, on the first Saturday in October, we celebrate a National Ostomy Awareness Day. And coincidentally, every 3 years, it's World Ostomy Day. And on Saturday, October 2nd, it's going to be World Ostomy Day all around the world. And it's just an opportunity for the world to increase public understanding of this life-saving surgery. And this year, it's also to help understand that health is a human right for everyone. The European Ostomy Association declared the motto or the theme for this year to be "Ostomates' rights are human rights." And UOAA was thrilled when we heard what the theme was going to be, because for years we've been working on an advocacy initiative advocating for utilization of the Ostomy and Continent Diversion Patient Bill of Rights in the United States. And these rights define and provide a guide to both patients and healthcare professionals as to what best practices are when receiving and providing high quality ostomy care. And it's during all phases of the surgical experience, from preoperative to discharge, and then also, during the lifespan of living with an ostomy. Patients are still entitled to health rights, long after they have surgery as well. And one thing I also wanted to bring up too, because sometimes we get caught up on the word rights, and that, the Ostomy and Continent Diversion Patient Bill of Rights, they are not legislated. It doesn't make them any less important or any less impactful. Quite the opposite. We're really hoping to drive a lot of systemic change with them. And just to give a little analogy, so to speak, many years ago when the American Hospital Association worked on the Patient Bill of Rights, they were never federally legislated. They were not a law across the country. But over time, over years, once clinicians, surgeons, everyone started using them and patients were demanding these things happen, they eventually became standards of care. And that's our goal for the Ostomy and Continent Diversion Patient Bill of Rights. We want all of the components that we have on there to become standards of care, where every patient receives these things, and no matter what healthcare facility, not just in the hospital during the surgical experience, but you might years down the road need hip surgery, you're back in the hospital, you should still have your ostomy reevaluated, your ostomy supplies provided to you that you need for your pouching system, or you might be need a home health nurse. So, all these different ways that you would still need care, you're still entitled to quality care. And in the United States, that is one of the Patient Bill of Rights. You walk into any hospital, you can see those Patient Bill of Rights now. And, quality care is one of those rights. So the Ostomy and Continent Diversion Patient Bill of Rights defines what quality care is for ostomates. I think we can just go on to the next slide now, Brett. What I'm going to do is real quick show you the different rights that are on the Patient Bill of Rights related to supplies. And then we're going to stop sharing the screen and we're just going to open it up to discussion. I have a few questions I'm going to ask the panel. And then after that, we're going to answer all of your questions as well. So one of the rights that we have on there is information on the variety of product choices available from manufacturers. A lot of patients leave the hospitals thinking that's it. They don't realize that there are many other products out there, many other manufacturers. Next slide, please. Another patient right is information about the supply ordering process. I can't tell you the number of calls that UOAA receives where someone left that hospital having no clue how to order supplies. Next slide. Another patient right is resources for obtaining supplies specific to patient circumstances, uninsured, underinsured. One of the highest call volumes we have are from patients or ostomates that selected a health plan with a low premium. Unfortunately, it has an astronomical high deductible, and as a result they're basically paying for their ostomy supplies all year long and they can't afford them. We also get many calls from people without health insurance looking for how they can obtain supplies. Next right. And then the last right, and this has to do with that ongoing lifespan of living with an ostomy, and that's access to specific and individualized ostomy supplies chosen in consultation with a healthcare professional to achieve and maintain a reliable fitting pouching system. That's it. I think you can stop sharing the screen now, Brett. And I'm gonna start talking to my people here. All right.
Thanks, Jeannie.
The first question we're going to ask are, what are the ways clinicians can prepare their ostomy patients for discharge, related to supply information? With that first right, information on the variety of product choices available from manufacturers. And I think I'm going to ask Sue first.
Okay, great. First of all, explain that you can't get your supplies usually at the local drugstore. This whole concept of getting supplies is very new to people. The only thing that is even similar is getting prescription medications, and you know how hard that can be. I would explain how you get your ostomy supplies. I would give contact information on all the major manufacturers, their patient support services, how you can get samples either from the manufacturers or the suppliers. I'm in favor of giving patients a list of their supplies. A lot of patients, they go out the door of whatever facility they're in and they have their prescriptions, but those quickly get taken for the supply obtaining process. And a lot of times patients are left with not any idea of what ostomy supplies they need. And if you have a list, if you make one list, you can use it in multiple ways. I know I'm not trying to add more work to nurses in the hospital, but you make a list with the supplies, the manufacturer's reference number, then you can use it in a million ways. One list you give to the patient, so that's their list and they know what they need. I would also give UOAA contact information, and please give supplies to bridge between when they leave your facility and their supply, they're able to get their supplies. The minimum would be 5 changes. And if you do a change every 4 days, that's 20 days worth of supplies. So that's a good way to start.
Awesome. Thank you. Barbara, did you have anything to add?
The only thing that I would add is when you do give the patients the list or their caregivers, emphasize that they may not need some of the things on there, and they may need some of them to go over it with their home health nurse when possible, because sometimes the patients will come home and they'll have a list of like 50 items and they don't always need all of that. But the list is so helpful if the acute care staff gives that to the patient, and especially if they give them a list of companies that they can get it, or if they tell them the home health needs to supply that or will supply that. But in my area in Tennessee, it is so helpful if they give them a couple of changes to get through until we can get in the home, or they can get them ordered through one of the major distributors. That is the most helpful thing, is to give them a 2 or 3, 4 changes before they leave the hospital.
Okay, and I'd also like to add that UOAA also has an ostomy supply checklist. And so we'd encourage clinicians, if you have a folder for discharge, planning purposes with educational information in there, that you print some of these checklists in there, also. You don't have to fill that one out, since, like Sue suggested, you give them this all-inclusive list, but then they have this resource for when they do go to order supplies, down the road. Brett, did you have anything else to add?
Jeannie, there were a couple of things, Barbara and Sue and Jeannie, you covered a lot of important things. So from the supplier perspective, I know this is going to sound crazy, but if you listened to our calls coming in from brand new patients, oftentimes they don't have their insurance information with them. Maybe you have them jot down their insurance information on that information sheet that you send them. I know that sounds crazy, but we can't, most suppliers.
Ooh, Brett, you just
Can't
locked
set up
up.
those accounts without that insurance information. Supplier, they can tell you, oh, I'm so sorry. Can you hear me now?
Yeah, now we can hear you. Maybe just go back and repeat the last couple of sentences, if you
Sure.
remember.
No, I think it's important. Make sure the patients have their insurance when they call into the suppliers. Make sure they have their insurance information. And you may have sent them out, but teach them how to measure their stoma so that they know their stoma size. There are some ostomates that know their stoma size and don't, but if we're going to custom cut for somebody, it's important for them to know their stoma size as well. Some suppliers do that. Again, their insurance information, and make sure that if it's a patient that's not responsible for their own care, maybe they're elderly, maybe they have a disability, make sure that the information that's provided to the supplier is where the supplier can reach out to that particular person. Maybe it's a spouse, maybe it's a partner, maybe it's a child, maybe it's a grandfather, whoever is responsible for that power of attorney or for that care, make sure that contact information is on that sheet as well, so that can be provided.
All right, that's
And
great.
I think that was it.
Okay. The next question, how are patients educated that their stoma may change? Especially I know from my own experience learning here, after a few weeks, it might not necessarily be the same size that it was when they left the hospital. And as a result, their pouching system might need to be reevaluated or changed. So I was wondering, maybe Barb, if you want to start off with how, people should know this kind of information, so that they're not afraid all of a sudden when they are starting to leak and don't understand what's happening.
Did you say me? I'm sorry.
Yeah, sorry. Yep, you're up.
Yeah, I really when they're in the hospital and they're told some of the things to expect before they come home, it makes a much better experience for them when they do get home and their family. Nothing is constant. Their stoma is going to change a little bit. There might be some other little surprises as far as output. And if the acute care person will let the patient know that, it's a lot less scary for that patient when they do go home, because this is a huge transition when you go home and you're all alone, or when you go to a rehab or a long-term care facility. They don't teach us a lot about ostomies in nursing school. I was an LPN and then an RN, and they just really kind of skim the surface. And so a lot of us don't know. And so the specialist or the person that is the last one to send the patient out, when they tell the patient all those things, like your stoma may change, it may get a little bit smaller, things to watch for. And that's usually why they don't order pre-cut in the hospital, is because it does shrink somewhat. But if you tell the patients that, it makes for a much better transition for the patient and the next level of care that they're going to.
Great, thank you. Steve, did you want to add anything to that?
Well, as a visitor, a certified visitor, I do talk to a lot of people, and one of the things, and the people that come to my support group, one of the things I always say is how you change your appliance on day one, at the end of 1 week, at the end of 1 month, at the end of 1 year, it's going to change. It's an ever evolving process. And one of the things that I know you emphasize, but I really, really always, when I was in servicing, tried to make sure is measuring. I think measuring is an absolute critical thing. We know clinically that it can change by as much as 2 sizes during the first 8 weeks. I always try to get nurses involved to make sure that they taught to be able to measure, because I think that's one of the most important things that I see that people have issues with about having it be the correct size. So 1, that it's going to change, and then 2, that measuring is a really important thing.
Thank you. Sue, did you have anything else to add, or?
I think change is the key word here. Also, I like to tell patients that if they gain weight or they lose weight, their abdomen is going to change contours. And sometimes, especially people with IBD, they get an ostomy and they start feeling better and they start eating and they may gain weight and then they need to be reevaluated. So to plant the seed that reevaluation is a good idea if things aren't working the way they were or if they change. And also, I think it's great to tell people what a leak is. A leak doesn't have to be leaking all the way down your legs. I mean, it could be a compromise in the seal, and that's important. So if you have a compromise in the seal, you need to have that addressed too. So it's a process of always looking and evaluating.
Okay, thank you. The next that we were going to talk about was information about the supply ordering process. So what should clinicians know about the supply ordering process and how do they learn about it and keep up with the changes in ostomy technology? Brett, do you want to tackle that first?
Sure, I'll tackle that as well. So, all right, so I think there's a couple of points here. One, I think it's important to understand a little bit about the process. Most patients can order on kind of this 30, 60, 90 day timeline. And I think it's important for them to understand that. I think a couple of things that are important to know is not every DME supplier is the same. Most of the major suppliers will accept a lot of insurances, but there are a lot of DME suppliers that don't accept certain insurances. There are certain DME suppliers that if your patients have a primary insurance, a secondary insurance, a tertiary insurance, work with your local rep to understand what is that supplier going to do for your patients? Because some suppliers, they don't bill secondary and they don't bill tertiary. They rely on the patients to do that, which adds a lot to the anxiety of the costs that are involved in these things. There is a practice in the industry called balance billing, meaning if, for example, with a Medicare patient, if the supplier accepts the payment in full that Medicare provides as payment in full, there's no extra billing to the patient. But some suppliers are allowed to charge up to an additional percentage on top of that. And it's the patient's choice. If they want to go to a supplier that balance bills and pay a little bit more, perhaps it's a mom and pop shop near the hospital, that's okay, that's their choice. But I think it's important for the patients for us to try to help navigate them through as many of the surprises as possible. I think it's important to set an appointment with your local rep. If you may be doing that already, but if you're not doing that, review some of those insurance. If most of your patients are coming through a particular insurance, understand the ins and outs of that. A lot of the HCPCS codes will vary, and we'll talk about this a little bit later. One thing I wanted to point out is we hear a lot about patients not being able to get certain products from certain vendors. It is really, really highly unusual that patients can't get a particular product unless there's something carved out in their particular insurance or if there's some kind of one-off with that particular supplier. That is the exception versus the rule, but we hear about it all the time. So encourage your patients just to ask questions, get connected with the supplier that they're comfortable with, and they have a choice out here as well. If things aren't going well, they should look around for another supplier.
Great. Sue, did you want to add anything else about what clinicians should know about the supply order process?
I think clinicians need to understand that the reason ostomy supplies are covered is that they are prosthetic devices that replace the function of a body organ. So they're not just, you don't run into the problems with disposable supplies, even though these supplies are disposable, they're prosthetics. I think that, sometimes what helps is the clinician has a basic understanding about insurance, and there are resources on the ostomy.org, the UOAA site for you. And also it's to, also help patients understand that they can look in their insurance handbooks, they can in the Medicare and U book, they can also call their customer service people on the back, that's on the back of their insurance card to get some help with that, to help them understand. So there are plenty of resources.
All right, great. Thank
Janine,
you.
is it okay if we talk for just a minute at this point so I don't forget about the ordering process for one of the things that we run into is when patients switch from commercial insurance to Medicare, the rules change. Would this be appropriate time to talk about that?
Yeah, sure.
Okay, so we were working with a really veteran WOCN who had a few patients that were challenged with switching from commercial insurance to Medicare. They were used to placing their 90-day order, and these two particular patients, they changed their pouch every day. Their commercial insurance was paying for 30 changes per month. All of a sudden, they flipped over to Medicare and didn't know that Medicare allows for basic Medicare coverage is 20 pouches, 20 changes per month as a general rule, 20 pouches, 20 barrier rings, barrier strips to match, things like that, which you're probably all familiar with. Most of the insurances base their coverage around that. What they didn't realize was that in order for those supplies to be paid for by Medicare, that overage, if you will, which is an industry term, there needs to be a matching prescription, which most physicians have already done and you have already done, but there needs to be matching chart notes that give a medical necessity, a medical explanation as to why they need those supplies and how many very specifically they use per month. And that can get a little confusing. The greatest nurse, the greatest surgeon can write a fantastic letter of medical necessity, and Medicare will not accept that. It needs to be in the form of an office visit chart note, which for a patient that doesn't know this and all of a sudden they are just switched over, they're assuming everything's going to go the same, it can create a lot of anxiety. So I think it's important to help any of your patients that might be navigating from commercial and changing over to Medicare. If they're ordering, if they're changing every 3 or 4 days, it's not going to be a problem. Everything's covered just the same. But if they are using more supplies, it can be confusing and very it can be a troubling time for some patients. So
Yeah, and I can tell you it's something that we're continually trying to change, because with CMS, Medicare, Medicaid, it's a very cumbersome process and a very frustrating process for ostomates that are affected by it. It's virtually it's very, very difficult to get that extra quantity. And again, it all goes back to having the right information that they're medically necessary in the documentation and those chart notes. So yeah, that's really good information to share. The other question, so we talked about how clinicians now, what they should know about the supply ordering process. What should clinicians be telling their patients about supply ordering? Barbara?
Well, it depends on what setting you're in. If they're in rehab, if you're home without home health, then the patient would be ordering their own. I really, when we discharge a patient from our home health agency, I really like to let them know that they have choices and the choices are endless, and they don't have to be stuck with one distributor or supplier. If they don't like the way things are handled or customer service or whatever, or the process, they can go to a different supplier. It's going to take a little legwork, and they can always get samples from the manufacturers. The manufacturers and the suppliers are so different. And a lot of the patients I see, they get those starter kits when they get home and they get overwhelmed, and they think that, Hollister, Comptech, Coloplast, they think that they are sending them the samples and that's where they're going to be getting their stuff instead of from the Byrams of the world. And so I like to say, well, no, they make the product and they send you these samples to let you try, but they can always try new things if they call the manufacturer, whether it's Hollister, Convatec, Coloplast, Marlin, New Hope, any of those, they can call them and they can always reach out. There's so much good information, and I'm not pushing UOAA because they're on here. It's just their website is just a wealth of information for clinicians and patients alike, and it's all written in a way that's so easy to understand. I really like to send them their way in the Phoenix magazine. A lot of the hospitals give that out to the new patients, but reach out to the manufacturers, and sometimes they can help you guide in the supply process as well.
I'm just going to interrupt too, from my own ignorance. So how do clinicians, does every hospital have a catalog from every manufacturer or a list of suppliers in the area? Because some suppliers are local, some are online, some are national. Where do even clinicians get all this information? Or are they on their own doing their own research, Googling ostomy supplies?
Google.
I'll throw it out to anyone to answer.
Well, I'll toss it out there that if you're working, the supplier you're working with should be able to provide catalogs to your patients. There's a big transformation in the industry going more towards a digital catalog, but some suppliers are still providing written catalogs that are very thorough with everything, with every product that they stock from the manufacturers to New Hope belts to Parsorb products and all the accessories. Some patients just need a one-piece pouch and they move on. Some
Mhm.
folks, they require a lot of accessories because of particular skin conditions. So if you're not working with a supplier that can provide catalogs, or if you haven't ask your supplier to provide you catalogs for your patients. They're really, really helpful.
Thanks. Sue or Steve, did you want to add anything else as to what clinicians should be telling their patients about supply orders?
No,
Okay.
I'm good.
You're good?
All the
Janine,
manufacturers will provide catalogs. However, what Brett said, sometimes they get confusing because they think they're buying straight from the manufacturer, which definitely is not the case. So, I mean, I would pass those out as if I was doing a support group meeting for people that wanted it. You know, there are some people that want all kinds of information and there's some people that don't. So I would make it available to those that do. I will say that most companies, and I'll say DMEs as well, are going to have a local representative to each particular hospital. Maybe not in every case. If you're in the middle of Wyoming or something like that, you may not. But for the most part, all the manufacturers and the distributors are going to have people out there that are trying to help. And I couldn't agree more. Ostomy.org. I mean, that's a website that everybody should know that's involved in the ostomy business. So.
Thank you.
Great, thanks, Steve. There was a good point made in the chat, Janine, about the patients can contact their insurance to find their in-network supply companies as well. I don't pretend that every medical professional on here is going to know every every insurance plan that every patient comes in there with, because there are so many out there. But I think it leads to something we were going to chat about, which is advocating for themselves. Some patients are very timid about advocating for themselves. They are intimidated by medical professionals. They're intimidated by the insurance company, and they're going through this tremendous, change in their lives. But I think something to encourage your patients is, if something's not going well with what's happening with your supplier, find another one. You're the customer. And encourage them to try the different options. If they're calling and they're on hold, go on. There's so many digital resources out here for placing orders. Every supplier has lots of different options for placing their orders as well. So, and that's been a big change in the last couple of years. Steve brought it up. Try to help them navigate who the suppliers are versus the manufacturers. You would chuckle at the amount of calls that we get. Say, "Oh, I buy my supplies from Coloplast." They don't know. So, and even if you tell them, they may not remember. But keep encouraging them that there's a difference between the supplier and the manufacturer. It'll help them navigate, and it teaches them to do it on their own.
I think Sue made a very good point earlier when she was talking about patients have to learn a little bit about their insurance, because I mean, it changes from year to year. I mean, I just recently went on Medicare and I just got my new book for next year. And I just recently ran into a situation where I got a phone call from a patient who knew that I used to work for one of the manufacturers. I'm being real careful, Jeannie, about what I'm saying, but I knew that I used to work for one of the manufacturers. And so she called and said, can you get me this product? Well, I happen to have some that I kept over from when I retired. And so I was able to pass on, but her insurance the provider had changed the parameters of what they could get. And so as much as insurance is complicated, patients have to be able to do a little bit of being able to know what they have, what they can change, and then what their alternatives are.
Right. By the same token, they should again self-advocate with their insurer. Get that letter of medical necessity from their physician, explaining why they need that product, and they might be able to get an appeal approved to get coverage of what they do need. So they do, again, it doesn't mean they have to accept what the policy says, when it's something medically necessary. They might be able to fight for it.
Sure.
The next patient,
Janine,
right?
Sorry to interrupt you. There was one more point that we wanted to raise about home health. So, Barbara, you used the term next step in the patient care continue, or the patient continuum of care. There is a lot of confusion when sometimes there's confusion. I shouldn't say a lot, when patients are discharged to go home, or if patients are discharged to rehab, or if patients are discharged to their home health agency. If you have a great partnership and you know all the folks at the home health agency, I think it's very helpful to encourage the patients how those supplies are going to be ordered, where they're going to be shipped to, and how they're going to show up. Most agencies handle them very similarly, but a lot of agencies handle them a little different. A lot of agencies will order certain products. A lot of agencies will match exactly what was discharged from the hospitals. And some agencies may not be working with a supplier that has all of those products as well. If you can help them navigate kind of what that next 30, 60 days looks like before they align themselves as a supplier, it will help eliminate a lot of confusion and help make that process a little more seamless, as complicated as it can be sometimes.
Thank you. That was good. I forgot about that point. I'm noticing the time and I'm like, oh boy, we still have a lot to cover here. So the next patient right was resources for obtaining supplies specific to patient circumstances, such as those that are uninsured or underinsured. So how can clinicians assist patients who are uninsured or underinsured? But I'll start with Steve this time.
The manufacturers all have programs available for help people that are uninsured. They are not a last forever. In some cases, they only last for a period of 90 days, but they do have programs available to help with that. I also strongly encourage you to check with your local ostomy support group. I know my group, I know Brett's group, we have a closet where people donate stuff to us. And so there's many times that I will pass out to different patients. And there are also some other companies that are, I shouldn't say companies, other organizations that are out there that can help with that as well.
Right. And I'll interrupt real quick just to say that on the ostomy.org website, we have a web page that lists all the resources for people from manufacturers to there are certain Facebook groups that have supplies. Sometimes you might even be able to call your local hospital. Again, these are more for a temporary basis to get supplies that you need, not long term. But it is a tremendous resource. And the last slide that we're going to show lists the URL website for that. Sue, did you have anything to add?
I just want to remind clinicians to please identify people with no insurance from day one and see what your facility process is. Because if someone has no insurance, maybe you're going to refer them to case management, to social work, to financial aid services. And I worked at one innovative hospital that had a whole program for people who had no insurance, and they were able to work with local counties to build their indigent funds. So you're part of a team in a hospital. So use that, especially if it keeps coming up. There's probably a lot of people who know how to do, those different things. But the important thing is to identify right, from the beginning. Underinsured is a different issue because some of the resources will not help people who have some insurance, but it's insurance that doesn't cover everything. So in that case, you might look at the sources that have discount supplies.
Yeah, there, and we have those listed too. There are some suppliers that offer low cost because it's all pay out of pocket, and so the prices.
Oh. And then the other thing is refer people to the local support group, because if you have to, these people live with us. Yeah. So I mean, they have a lot of tips on how to conserve your products, and they're the ones that know. So that's a great place to send people.
Great, Brett, did you want to add anything?
There's been some really good points added, but something that we talked through in that underinsured. So some of the suppliers will provide hardship waivers. So for example, if you have insurance, but you can't afford your copay or your deductible, you can apply for a hardship waiver. Most of the companies have it right on their website. It's a process. Someone that is in the situation is probably used to filling out a lot of paperwork, but sometimes that that paperwork is always considered by the supplier. So encourage them to ask if those are available. I think we talked about the manufacturers. Some of them have different support plans, and all the suppliers have a discount cash plan that patients can take advantage of. The supplies are still expensive even on a discount cash plan, but sometimes that's just enough of a break that gets them the supplies they need until they can get figured out. Sue, you mentioned something really critical. So many patients that call in and they're struggling through this either lack of insurance or they're on a state supported or a Medicaid plan don't realize that they can get a caseworker involved with them to help them navigate these things. Sometimes it's very straightforward. You make X amount of dollars, you qualify, but then the next month you don't. It can get, and then all of a sudden it can get really complicated. One month you can get your supplies, one month you can't. And gosh, I feel for anybody in those shoes. But encourage them to work with that social worker, work with that caseworker to help them advocate together for themselves.
Okay, thank you very much. Looking at the time now, we're actually on the very last right related to supplies. And that, again, this is during the lifespan of the ostomy, having access to specific and individualized ostomy supplies chosen in consultation with a healthcare professional to achieve and maintain that reliable fitting pouching system. I wanted to ask, what access to supply issues do you witness in the community now, if any, and how can people overcome some of those issues? Barbara, did you have any that you've witnessed?
Oh, come back to me.
I'll have a couple of thoughts here, Janine.
Okay, Brad, thanks.
One of the well, it's something that maybe I should have pointed out before. Somebody popped it in the chat that every insurance company is a little bit different. Some require a whole lot of paperwork to get their supplies. Some require no paperwork. You accept a prescription, you go and you get it. Oftentimes, I witnessed so much back and forth over getting that paperwork done of the authorization, and then you need a referral from your PCP, but I haven't been to see a PCP for 2 years, so they won't sign anything. Patients just throw up their hands. Help them through the process. The suppliers will help them through the process. Most of the suppliers want to make sure that the patients get their supplies. I live in this world that there's a patient behind every phone call, every text, every email. We want to help them. We talked a little bit about the Medicare overages. We get some feedback from patients about, and we've heard it from our medical professionals that we deal with as well, and that we work with side by side, about patients having their products switched out, where you might get a proprietary brand of an adhesive remover or a lesser quality of a pouch because it's less expensive, and that's what my insurance plan will take care of. Work with your supplier. If you get something that you didn't order without them telling you about that, that's not the way it's supposed to work. They're supposed to alert you ahead of time if something in that insurance policy is preventing them from sending that supply out. One of the challenges there are a lot of consolidation going on in the manufacturing world right now. There are a lot of companies that are discontinuing old legacy items that they just don't sell very much of and converting patients over. Your supplier should be alerting you before that comes out, but that creates a major problem for somebody that's been using the same one-piece pouch since they were discharged from the hospital 15 years ago. That can create a major problem. And then the last little piece with supply issues, we find them on some of the Medicaid plans definitely limit. So I'll walk you through a scenario that we're helping a patient with a couple of weeks ago. The Medicaid plan wouldn't cover more than 5 extended wear barriers, convex extended barrier wear for the month, but that plan would cover a standard wear convex barrier at 20 per month. So while it might not have been ideal for the quality of life and the wear time, we worked with the nurse, and the patient was willing to advocate for themselves to help find me something because I'm changing a little bit more. So there's usually a way to work with your supplier to figure these things out. And I consider that an access to supply issue, and we're seeing it more and more on some of the Medicaid plans, and we're seeing it a little bit more with the ACA plans from the marketplace plans. Sorry, that was a lot, Janine.
Yeah, no, that's good. And that's another big priority for UOAA that Sue and I have been working on regarding that. Some people call it non-medical switching, but that substitution of products. And we actually have a, position statement to help, patients when they encounter those issues, again, to try and, again, contact your supplier to see, why it happened. Again, you have to ask questions and speak up, and, maybe there was a good reason for it, but, again, you want to make sure if it doesn't continue, if that's the only product they're going to keep shipping to you, you might need to find another supplier. And again, for those who say it was an insurance example, like you gave earlier, using this as a tool, it can help patients, even with their insurer, so they understand some of the medical consequences of what happens when they don't have the supplies that they need. Barbara, did you have anything to add? The question was, what access to supply issues do you witness in the community? It's okay if Brett covered everything.
Well, most of the time, the access to supply issues that I see are one specific example just pops up in my head where one DME distributor, whatever you want to call them, was limiting their patients to a certain brand. Instead of the HCPCS code, they were limiting them to a brand, and that wasn't working for the patient. And I just flat out told the patient, use a different supplier. You don't have to use them. And I'm not brand loyal to, Hollister, Convatec, Coloplast. I'm not brand loyal to any of the distributors. I want what's best for the patient to have 3 to 5 days of reliable, good wear time. That's what I care about. And whichever distributor or manufacturer makes that happen, usually when people are having trouble and they're needing overages though, they need to see an ostomy nurse or a visitor from the UOAA. We don't have hardly any of those in my area, which is sad that we don't, but those are so helpful. But usually if you can talk to somebody on their level and find out what's going on with them, why do you need 23 pouches a month? Really? I mean, isn't that tearing up your skin? Maybe their supplier is giving them crappy products. I think it's all about communication, and just like with the distributors and the patients and your friends. I mean, I have people call me, and I have a donation closet just personally where people don't want to throw this stuff away. And sometimes somebody will call me and say, hey, I ran out of supplies this month. Do you have any, I can't even think of a number and a name off the top of my head. And I'll look in my closet and say, no, but I have this if you need it, or I'll help them. And there's also a thing called an LCD, and you can't see that, but it has the quantities, the HCPCS codes and everything. And I don't expect hospital people to know all this at all, but I like to show patients and let them know that it exists, because to me, that's saying that you have the right to these supplies if you have the condition that meets it, and not to take no for an answer and to stand up for themselves.
Great, thank you.
Barbara, I think that's a good point. Janine, there were a couple of points the couple of questions popped up in the chat I think would be appropriate to just answer here.
Okay.
We talked, one's about discontinued products and one's about supplies not readily covered. So we talked a little bit about the discontinued product, and Barbara, the way you think about this is the way you think about this is great. 3 to 5 days wear time, doesn't matter what manufacturer. I think if you haven't had a chance to, if your facility is aligned with a certain manufacturer, that's fine. If you have referred your patients to a different manufacturer to get samples and haven't asked them how that process goes, the support that's out there from the different manufacturers, especially when there's things being discontinued, patients sometimes they're scared to speak up. They think there might be a problem. Encourage them to try a different product so that they can get that 3 to 5 days wear time. It breaks my heart when one of those patients calls up and I'm changing my appliance twice a day. Gosh, go see one of these great WOCNs out here. There's probably something you can do about it. And advocate for yourselves. How can we advocate for supplies not readily covered, such as fistula pouches? I think it's important that's a tough item. Steve, you want to take that one?
I don't. However, I completely agree. One of the things I'm glad I'm retired, that I don't have to deal with that anymore, because that really was a major issue. Fistula pouches are really considered to be almost like wound care products. So it can be a real hassle. As working for one of the manufacturers with probably the best fistula pouch on the market, I ran into this more than I care to think about. I will tell you that I used to give away pouches to people, like 1 or 2 at a time, to be able to handle particular situations. But there's no question, it's probably one of the most frustrating parts of dealing with wounds / ostomies is so many times fistulas go hand in hand with an ostomy. So I wish I had a great answer for it, but I feel your pain, as Bill Clinton used to say. But it is, you really just got to kind of stand up and jump up and down. And most manufacturers, I think, will help to a point. But if you've got somebody needs one long term, try the wound care route, because there's wound care has other different HCPCS codes and different ways of being able to do things. But
Yeah, and I can,
I
can
understand
tell you,
how that's a real problem, and I wish I had a great answer for you. But
yeah, I can tell you though, that it is an advocacy priority to get fistula supply coverage under the CMS. So we working with the WOCN Society. They're taking the lead on that effort. We recently had a meeting with CMS, and several of the big manufacturers are involved in those discussions as well. So there are a bunch of stakeholders hoping to resolve that issue, but nothing happens overnight. And something like that, because it's a defined benefit category, might need to be changed legislatively. So we're trying to figure out every possible way we can without having to go that route. So it's definitely a priority that's being looked at and trying to be addressed. Another question that we had, because we're going to be running out of time soon, was how can clinicians support self-advocacy for their patients? Sue, you want to say anything about that?
I think it's important to identify the patients right away from the beginning who you think are going to have self-advocacy issues, and enlist helpers. You know, I've sometimes said to patients, like, who are you going to call when you're at home and you have a problem with this? And get that person in the hospital, get them into the facility and teach them. And also maybe just model and walk through some things, how to use resources to support people with self-advocacy.
If you have time to take them on a tour of, www.ostomy.org, it's just even showing them the way. I haven't put it on their phone. There's different apps out there that can help patients. And I think you make some really good points. Help those that need the help, and teach the ones that, teach them how to fish, and they'll figure it out. I think that's a great point.
Barb, did you have anything to add regarding helping your patient self-advocate? That's what we're all about here.
I try to tell everybody that I meet, call me, email me, text me, get on the WOCN website, get on the UOAA website, reach out to people, because most people, like Janine and all the other people at the UOAA, myself, Sue, and I'm sure Steve and Brett, reach out to people, and somebody will help you or point you in the right direction of somebody in your area that can help you. Networking is, don't be afraid to reach out to anybody and say, hey, just ask for help.
Great. I'm looking at the time now, so I'm thinking maybe I'll just say, do any of the panelists have any important message you want to get across regarding the rights for access to supplies? And then we'll just open it up to questions if there's any other questions. You want to do it that way instead of asking our last two questions? Did you have any last thing you wanted to share? We'll start with Steve.
I think there's so much information out there that it can be somewhat overwhelming. As much as I love the UOAA website, and I do, there's a lot of stuff on there. I am a huge proponent of support groups. Barbara says she doesn't have really a support group in her area. I'm sorry to hear that, because I am a big proponent of support groups, because I think there's a plethora of information. The other thing that I guess I've learned in my 24 years of being an ostomist is that the ostomy community is open to helping anybody and everybody. So what you just said about there being so many people out there that can help, I call WOCNs the angels of nursing. I mean, every nurse is, are great, but the WOCNs I've dealt with in 24 years are tremendous. Unfortunately, not every hospital has a WOCN, but there are ways to be able to get information, whether it be through the ostomy.org, whether it be through the manufacturers. Again, a company that I used to work for had WOCNs on staff to be able to talk to. So you can get to those people, but you just kind of got to ask somebody and figure out a way to do it.
Yeah, and that's something that we're trying to achieve with the Patient Bill of Rights, that it's not just access to supplies, it's about access to that quality care. And, we highly recommend that it's care provided by someone with a certification in ostomy. Doesn't have to be a full WOC nurse. It could be an ostomy management specialist, but someone that has that knowledge and training on how to care for an ostomy. And again, we're hoping, you know, more facilities start adopting these rights and recognizing these things, that's how we'll, you know, start to drive change. We'll start to see more of those nurses choosing that profession, and facilities, you know, supporting their nurses by providing the cost to cover the expense of getting that certification. And, you know, slowly but surely we are definitely, you know, seeing those changes. So anyone else have anything else to add before we open it up to questions?
Just wanted to say, remember for the opportunity for reevaluation. If things change and your medical condition change, if you're no longer able to independently care for your ostomy, it's time for an evaluation, and that can be covered by the insurance, because if you have a change in caregiver, or you have a situation where you have to learn how to care for your ostomy in a different way. So reevaluation needs to be part of the change process.
Great.
One other thing I just thought of, for maybe most clinicians know this, hopefully, but telehealth has become such a big thing. I mean, there's not many good things that came out of the pandemic, but I think telehealth is one thing that kind of got moved along faster because of it. And I know, again, the company I work for had a telehealth program for people, like where Barb said, there's no support groups. Well, they can access by computer to get help that way as well. So telehealth is something that's going to do nothing but get more and more available. So that's just another thing that people need to be looking out for.
Great. Brett, did you want to share the last two slides? Did we want to take any other questions? Does anyone have any questions? You can type it in the chat or raise your hand.
Yeah, we haven't had any other questions come in the chat.
Okay, all right. So then the last slide we have here is some of the things that we mentioned. That's an image of the supplies checklist that we have. Again, there's the resource for people that might need supplies, whether it's, you know, they're not insured, or again, there might be a disaster, you know, where you need emergency supplies. And I think, Brett, you were going to talk a little bit about that, right?
Right. You know, yeah, thank you for the reminder. So one of the challenges that some of our patients are facing in different parts of the country with this extreme weather events, patients calling in that were displaced because their house was damaged in a fire or in a flood, they had to leave. Imagine being in that situation where you had to leave so fast that you left your ostomy supplies and now you're staying with your brother's cousin's uncle, maybe 3 states over. Work with your supplier. They'll help you get some supplies where you need to go. They'll work with you. If they won't work with you, you're working with the wrong supplier, but they'll get you supplies. They'll work you through the insurance. Insurance companies will help. It's another one of those advocacy things. Teach your patients to contact and ask for help.
Great. Well, I mean, I guess that's it. That's all the time we have. We actually went a little bit over time. So we thank everyone for joining us, and especially a big shout out. Thank you to all the panelists for sharing your experiences and expertise. And UOA, thanks Byram for your continued partnership with us. And we just wish everyone a very happy World Ostomy Day.
Happy World Ostomy Day. Thanks for coordinating this, Janine, Barbara, Steve, Susan. Thanks for being on today. It's huge. We can learn from each other. I've learned a lot from each of you that are helping us make it easier to do our job for our patients too. So thanks to everybody who joined. It says a lot about you that you jumped on to spend an hour with us. So thanks for supporting the ostomy community. You definitely make a difference.
Thank you.
Thanks.
All right. Good night, everyone.
Good night.